Thank you for the introduction. Last name is Hakkesteegt, so it was close. Good try. I'd like to give a talk indeed about the Magnify trial, which assesses HIFU treatment for desmoid tumors. So in short, what is HIFU treatment? It's a non-invasive, non-ionizing thermal ablation technique, best described by the image on the right side of the slide. So ultrasound beams are focused on one central point. Only at that central point does it cause local heating. So we call that the focal point. If the temperature rises above approximately 60 degrees Celsius, it causes tissue coagulative thermal necrosis. And the advantage is that the surrounding tissue is spared. And desmoid tumors are considered opportune for this treatment as well. So as with all treatments and new treatments, there are certain advantages and disadvantages. Advantages are that it's relatively non-invasive, there's no radiation exposure, it's a very precise treatment, and also it can be repeated over time. However, certain disadvantages are especially the risk of skin burns, the thermal damage to adjacent structures. It can be relatively painful for some patients, and also it's time-consuming. And one of the biggest drawbacks is that not all patients are eligible for the treatment. So at UMC Utrecht, we make use of the profound sonolievie system with a direct cooling system. And before the treatment is initiated, the radiologist performs one test sonication. And this is to determine the exact amount of energy that's needed and also the duration of the sonication. So this can depend upon several factors, mainly upon the T2 signal of the tumor, but also on the depth and the location of the desmoid tumor. And all cells are manually placed by the radiologist. So that's shown by the green ovals on the right side. So those are the treatment cells, and those are placed in different layers within the tumor. So some studies have been conducted already, mainly retrospective studies, which describe relatively good results in terms of reduction in tumor volume, also decreases in pain scores, and improvement in quality of life. However, as stated, retrospective studies, and we aimed to perform a prospective study, which leads to the Magnify trial with the primary aim to assess efficacy of HIFU treatment for desmoid tumors, efficacy in terms of a newly developed personalized satisfaction score, meaning what is for the patient a clinically relevant improvement. So it's prospective, designed in 2 stages, and it's a multi-center study in the Netherlands. And we include patients with the age of 16 years or older that have failed active surveillance, either in terms of symptoms or in terms of a tumor that has grown over time. And the exclusion criteria are patients with FAP, intra-abdominal tumors, tumor size bigger than 12 centimeter, or patients that have had active treatment within the past 12 months. We calculated that we would need a minimum of 13 patients to be included in the study, 8 patients in the first phase, 5 patients in the second phase. And it's determined as an effective treatment if we have reached a patient satisfaction score of more than 40%. So 3 or more patients of those 13 patients. This is what it looks like schematically. So currently we have had more than 1 successes. So we are in the second stage of the study, still recruiting patients. And if we have more than 3 successes, it's deemed effective treatment. So patients are ideally treated with 1 HIFU treatment. However, if necessary, they can get a second treatment within the study. Then for the primary outcome measure, the patient satisfaction score, this means the patient would reach his or her own personalized satisfaction score. So this is a scale ranging from 0 to 10. And we ask patients at several time points before the treatment how they would currently rate their health concerning their desmoid tumor, and with which score they would be satisfied after treatment. So for instance, a patient would currently rate their health a 5, and they would be satisfied with a 7. Then 6 and 12 months after treatment, we ask them again, how would you currently rate your health concerning your desmoid tumor? And in case they rated a 7 or an 8, that would mean, in this example, that the patient would have reached the personalized satisfaction score. Of course, we have several secondary outcome measures, mainly objective outcome measures concerning the tumor itself. So changes in tumor volume, also viable tumor volume, rate of non-perfused volume directly after the treatment, non-progression rates, number of re-interventions, adverse events, changes in pain scores over time, and the changes in quality of life over time. This is what a study scheme looks like. So we see patients regularly during at the outpatient clinic. We make MRI scans during follow-up. We send them questionnaires, and we are mainly interested in the outcomes at 12 months follow-up. So this is what the recruitment currently looks like. So we have successfully treated about 11 patients. 4 of these patients have completed the 1-year follow-up. Other patients are still in follow-up. And for now, as we don't have all results yet, I would like to quickly give an insight into the results of those 4 patients that have completed the 1-year follow-up. So these are their baseline characteristics. So mainly females with the mean age of 41 years. Tumors in the lower extremities, the back and the thoracic wall. Unfortunately, we don't have all tumor mutations known. Most are unknown of these 4 patients. All tumors are primary tumors and none have had a prior treatment. These are some details about the HIFU treatment itself. So the mean temperature was well, a bit below 60 degrees Celsius. The mean treated volume was 82%, and it took approximately 3 hours to treat the patients. So we asked the patients directly after treatment, day 3, 7, and 14 after treatment, what their pain scores are to assess the pain that's directly caused by the treatment. And we saw that the mean, these are by the way NRS scores, and that the mean pain scores after the treatment were 3 and decreased to 2. The worst pain score was 5, which did not worsen throughout the other days. Then for our primary study outcome, we saw that about half of the patients reached their own personalized satisfaction score or higher, so 2 out of 4. The other 2 did not reach the personalized satisfaction score. However, they did reach a higher satisfaction score when compared to the scores before treatment. So to give a look into the exact scores, one patient wished a 7 or wished an 8 and had a 7. The other patient wished a 6 but scored a 5. Then for the response rate, according to RECIST, we saw that half of the patients had stable disease at 12 months follow-up, 1 patient had progressive disease, and 1 had regression. These are the exact outcome measures. And for patient 3 and patient 4, the patient with regression and stable disease, those were the 2 patients that also reached their personalized satisfaction score. We had no re-interventions within these study participants, and only 1 minor adverse event, which was a folliculitis, which resolved spontaneously. Then we assessed the pain scores during follow-up up until 12 months after treatment, and we saw a mean decrease in NRS pain scores of 2 points, both in the worst pain scores and in the average pain scores. So before MR HIFU treatment, the average pain score was 6, which decreased to 4. The worst pain scores was an NRS 7, which decreased to 5. However, 1 of these patients had an increased pain score. So these are the 2 patients that did not reach their personalized satisfaction score. And we had a look into the tumor characteristics based upon the MRI. For the first patient, we saw that the T2 signal increased during the follow-up, even though the NRS pain scores did not differ, and the tumor regrew and increased in volume. The second patient, well, the treatment volume was just 50% due to unwanted heating during the treatment, with a non-perfused volume of 50% directly after the treatment. And we saw during follow-up that the T2 signal remained stable but high, and the tumor regrew, increased in volume. These are some examples of a patient that did not reach the satisfaction score. So this was the patient that, well, had a suboptimal treatment. 50% of the tumor was treated with a non-perfused volume of 50%. And we saw that, well, the tumor volume slowly increased a bit. The T2 signal remained the same. This was one of the patients that did reach the personalized satisfaction score. We saw what was successful treatment, so the non-perfused volume was 80% directly after treatment. We saw that the tumor size decreased in time, and the T2 signal decreased, and also there was an absence in symptoms. So these were, of course, only 4 patients that had completed the 1-year follow-up. And in these patients, we saw in half of the patients good results in terms of satisfaction, decrease in pain scores, and reduction in tumor size. However, the non-perfused volumes and the changes in volume, so that's the data that we still have to analyze. So I couldn't show that to you today. However, there were 2 patients that did not reach the satisfaction scores. They had a tumor regrowth, and one of the patients had a suboptimal treatment. So also the treatment characteristics, so how successful is the treatment itself, does seem to influence the outcomes. Well, we're still recruiting patients. We still need 2 inclusions, so hopefully we can end the recruitment by the end of this year, and hopefully we have the study results by the end of next year. So with that, I'd like to thank you and happy to answer any questions.
Questions? Oh, yeah, go ahead. You think the patients from there?
We could talk about it. Yeah, definitely.
Because actually, all of my patients, or a lot of patients, always ask about local therapy. Even if we are moving more and more to systemic therapy for the field, patients are always asking about local therapies, which is not surprising in a way, because it's a local disease in a way. But so it's actually very good.
Yeah.
I have a bigger question for the not necessarily for you, although you can answer, but maybe for the whole group. So for these local therapies, I sometimes think of it as if we're doing N-of-1 trials for patients, because there are some unusual conditions in which you never have enough patients to be able to do a large series that's adequately powered, and because all the tumors happen in different spots, it's hard to get large groups together. And the concept is you go in order between things with very low side effects to things with more potential side effects and complications later on. What do you think about that concept? Should we be thinking about, for local control, N-of-1 kind of trials that patients are over their own control? You try, least things with least amount of side effects first, and then go up over time if they're having trouble.
Sorry.
So what do you think about the idea about, for the local control of the tumor, the local control, you do it with, you do like not necessarily, it's not like a trial, like a randomized prospective trial, but you start off with things with the lowest potential side effect. And then if they're still having symptoms from or problems from, they still need local control, you then go up the ladder to try things with a higher level of side effects. Make like a list. What has the lowest potential complication rate or side effects? The higher ones, you go down the list, and you can compare their outcomes, like an N-of-1 trial. Each patient being their own trial. You don't have enough patients, but you don't think it's a good idea?
I think it's especially here, I think it's a fantastic idea. The big challenge is, how do you assess what is your earliest point of assessment for success?
Could be, you have to think about it. Could it be symptoms?
Yeah.
Based on symptoms of pain. Yeah.
This is where the circulating biomarkers, the CFDA, could imagine cycling through concepts and then identifying tumor fraction, certain changes.
But maybe if it's the symptoms what the patient has symptomatically is most important, maybe that's not as important. If you're talking about the patient's symptoms and what problems they're having from the tumor for local control, that's something they can tell you.
Yeah, I'm not a physician here, but I think this kind of N-of-1 empiricism where you're trying things, but it might be part of, you could set it up so it's part of the learning system, so you're capturing information somehow in a systematic way, so that a large number of N-of-1 experiments actually teach us something in aggregate in this community.
Yeah, that's often what we do for pediatric in pediatric rheumatology. They do that, where they just don't have enough patients with any particular diagnosis to figure out to do large scale comparative trials. Do you have a couple comments?
Right. I just want to ask something to the presenter. Have you had in your institution the opportunity to compare the outcome of HIFU against cryoablation?
If you want to do that in the future, is your question?
Have you started?
Yeah, we haven't started that yet. But I think as soon as we have the cryo-desmo results, then it would be really interesting to compare it to these results as well, and then see which therapy might be better, because I think that's a question that we get quite often from patients, like if they should go for cryotherapy or HIFU therapy, because they're sort of the same local therapies. So I think that would be really helpful if we could guide and tell them which treatment has better results or not.
Go ahead.
I'm not sure, as we discussed in the last consensus meeting, that we can treat patients because of the pain. I mean, we always said let's not treat patients just for pain, but try to treat patients for desmoid that progress. And of course, pain is an important issue, but we cannot propose a local treatment just for pain. So it's difficult what you said. Let's
So maybe misunderstood. So I'm talking about someone, let's say you're starting someone on a chemotherapy, gamma secretase inhibitor. They have residual tumor still. They have some residual tumor, and it's causing them a problem. They have symptoms from that residual tumor. It's gotten smaller, but they have residual tumor. Is there something you do for their residual tumor, helping their symptoms or pain? That's what I was talking about.
no, also this is what we discuss about local regional treatment after medical or systemic treatment. We said that there is not any sense.
I'm bringing up, well, if they're having symptoms, why not give them something to make their symptoms better?
Because you should compare medical treatment for pain and local treatment for desmoid. If you want to say that local treatment is better than systemic treatment for pain.
Yeah, no, I'm talking about something different. So you're talking about not necessarily as a study, as a patient that you're managing when they're having a problem. And there's options, there's maybe localized options that can help with symptoms. So would it be worthwhile?
I would treat
I bring that as a question.
I would treat just the pain and not the desmoid.
Well, it depends on what it would have to be an individual patient problem, a residual tumor or whatever, and they're having symptoms from it. That's what we talked about. So these types of therapy. Not a comparison between a drug therapy, a local therapy, but both. That was my query. Should we consider that? For those patients who have symptoms and problems.
So I think that there's a difference between, there are patients that have treated desmoids that have, a T2 non-enhancing mass of scar tissue, which is not likely to aggravate again, but it's still causing discomfort. Where I think more treatment for desmoid is not likely to solve their problem, which needs to be separated from a not progressing but still viable desmoid, where you may get symptomatic relief by treating that tumor, right? So I think it's a little bit more nuanced than just saying it must be lower to treat, but I also think that there are patients who have been treated where doing a local therapy causing the scar to scar more.
Or make it better. So what do you offer them?
What's that?
So what do we offer them?
So it's a problem. These patients have been treated, but their pain is not better, but their tumor looks by all indications to be not viable, not progressing. And I wish it's a different answer, but I don't know that I think a procedure solves that problem.
I'm wondering, do you think that there's a basis in this for what do you think the likelihood of cellular heterogeneity having a role in this?
Certainly could, right?
Well, because that would justify it, but then we would need, again,
I'm bringing this as a query to think about. An issue to think about, because we've been talking about some novel types of local therapies, a little bit different that we've been talking about, and that was sort of my query. So for those patients, is it worthwhile if you do it in this study? You have to look at their outcomes.
I think my point is that for a treated tumor, I think that I don't know if we're getting or not, but I think what you're saying was that for there, you're trying to manage the pain. So what your comparator should be analyzed, right? So it's what's better, is it pain medicine or your procedure, right? It's not, you're not looking at progression at that point.
That's why I said you do it anyway. You try, let's say you try pain medicine's not working.
I don't know what confidence I have that it'll work in the health. I think that will.
So you have to figure, that's, you'd have to do that kind of study to be able to figure it out.